Good afternoon, everybody. Thanks for staying with us for this important symposium. I am Dr. Julian Bustin, head of the Geriatric Psychiatry and the Memory Clinic at INECO, and one of the members of the scientific committee of this symposium. I have the great pleasure and honor to introduce the next conference by one of my mentors, Professor Craig Ritchie. He is the Professor of Psychiatry of Aging at the University of Edinburgh. He's the Director of Brain Health Scotland. He has over 250 academic publications and secured almost £100 million of grant funding in his career up to date. He will talk to us about a very relevant topic today and even more important for the future of public health. He will talk to us about brain health services, a new route towards dementia prevention. Craig, we are all listening to you.
Thank you so much, Julian. It's so lovely to see you again after so many years since we worked together. So thank you for that welcome and for giving me the opportunity to present on this topic. So what I'd like to do over the next sort of 20 minutes or so is just tell you a little bit about an initiative that we started in Scotland about 2 or 3 years ago, which I think, or we think, is really a different way of providing clinical services for people with much earlier stages of neurodegenerative diseases than we're possibly able to do with the existing model in memory clinics. And to do this, I think, properly, what I'd like to do is really split it into 2 parts. Number one is just have a little bit of a sort of scientific foundation around why we think it is important to gear services towards people much earlier in the course of the diseases that, if left untreated, would lead to dementia. And to do this, I'll talk a little bit about this research direction generally, but maybe show you also some data from a couple of the projects which I've had the privilege of leading over the years, namely EPAD, European Prevention of Alzheimer's Dementia Programme, and the Prevent Dementia Programme here in the UK and Ireland. And then for the second half of the presentation, talk a little bit about how we've taken those observations that we've been making in the clinical research actually into practice. So I'm not going to give a pathology lesson here, but I do think it's worth grounding ourselves in where this all started. Auguste D on the right was the first patient described as having Alzheimer's disease, Alice Alzheimer on the left, in 1906, when she died after an illness of about 5 years. And what about Alzheimer's, of course, did back in 1906, well over 100 years ago, was described at post-mortem key pathological lesions, namely the neurofibrillary tangle and the amyloid plaque, as well as a much more shrunken brain than one would have expected of a lady in her mid-50s. And these hallmarks, if you like, of Auguste D's brain are what we now know to be Alzheimer's disease. But of course, the challenge in 1906 was that to identify these pathologies, one had to wait to post-mortem. And that was very much the case until later in the 20th century. So necessarily, we could only really define or describe or even diagnose Alzheimer's disease when it got to a dementia stage of illness, when people had overt clinical symptoms. The problem being, of course, is the brain was able to protect oneself symptomatically, if you like, before disease reached a very, very late stage. So what we were unable to do until the 1990s, namely to identify this disease before post-mortem, should have been in some ways revolutionized in the late 1990s, when through neuroimaging and looking at CSF biomarkers, we could actually measure the disease directly. So this syndromal or symptomatic approach to defining Alzheimer's dementia could have been, and perhaps should have been, pivoted towards a much earlier diagnosis of the brain diseases that lead to the dementia syndrome in later life. So another way of thinking about this is that necessarily for many decades, we had to think about the end stage of this disease process through the lens or through the prism of the dementia syndrome. However, what we're now able to do, and what we're obviously trying to set up clinical services to be able to do, is to shift our gaze earlier into the course of the disease process. And I'll show you some data in a minute that really helps, I think, endorse this view that the diseases leading to dementia have their genesis at their origins at least 20 or 30 years before the dementia syndrome is diagnosed. On this slide, you'll see this term silent period. And I often say the silent period before these mild, moderate, severe problems emerge is only silent because we're not listening properly. And were we to tune in to some of the changes that are taking in the brain, we may be able to, if you like, amplify and hear some of those issues that are going on at a very, very early stage. And of course, it probably goes without saying that if like in any other branch of medicine, if one were to be able to identify disease at its earliest stages, it's probably going to be the most amenable to therapy. The other factor that comes into play here is not only what are these diseases, how are they beginning to emerge, how are they developing, how are they evolving, but why? Why are people getting Alzheimer's disease in their 50s and their 60s, and then, of course, dementia later on? And what this slide is a very busy slide. All it's trying to illustrate is that there's multiple risk factors for Alzheimer's disease. And of course, there's other factors which may confer some degree of resilience. So there's two things that really come out of this. Number one is the multiplicity. There's no single cause for sporadic Alzheimer's disease, but also they have different potencies or different impacts at different stages of the life course. Now, this is a publication from almost 10 years ago now, but Jill Livingston, a friend and colleague from UCL, was able in some ways, working with other epidemiologists and other academics, to really, I think, communicate what I think a lot of us knew already in the Lancet Commission report, which identified that perhaps up to 40% of Alzheimer's dementia was preventable if you were to be able to manage risk factors which have different impacts at different stages in the life course. Now, when this paper was published, what we realized is there's two things we needed to do. Number one, the two challenges. Number one challenge was, how do you turn these epidemiological observations into actionable individual prevention plans and indeed health policy? And the second, which is probably less important a topic for this particular presentation, but how do you take these epidemiological associations with dementia risk and try and identify what are the mechanistic underpinnings for this? So for instance, we talk a lot about the Mediterranean diet being protective for brain health, being protective for dementia. Wouldn't it be lovely if we could work out exactly why the Mediterranean diet was so helpful? Because that would help us, I think, understand these disease processes and, dare say, maybe even identify new targets for pharmacological intervention. So one of the things that we have to do is be able to incorporate all of these data, all of these observations into what we call four-factor modeling. Now, what I'm communicating here, I'll talk about again later on, but that is, if you want to take an individual and actually define what their risk of developing a dementia syndrome or a progressive Alzheimer's disease in the future is, you have to take data from various sources to create these risk prediction algorithms. You have to look at risks, both fixed and modifiable. So fixed would be genetic risks, modifiable risks would be things like lifestyle, comorbidities, etc. You have to look at the expression of the disease through biomarkers, so neuroimaging, CSF, or blood-based biomarkers. You'd also want to look at the expression of the disease through symptoms, cognition, behavioral changes, sleep changes, mood changes, etc. And critically important in this four-factor model, if you like, the fourth dimension to this is time. What can you learn from looking at how these things change, the disease biomarkers, the cognition, etc., over time? It's much more meaningful, as I'm sure everybody knows, that if you can see hippocampal, a low hippocampal volume in a cross-sectional scan, it doesn't tell you as much as if that scan or if that hippocampal volume was to reduce over maybe 2 or 3 years in terms of whether or not this is Alzheimer's disease or just the normal shape of the individual's brain. So where are we getting these data from? Well, from a scientific or from an epidemiological perspective, there's a lot of studies that are taking place across the world, including some I know of in South America, which are collecting huge amounts of very high quality data. I'll talk a little bit about the Prevent Dementia program, which is individuals, several hundred people now, aged between 40 and 59 at baseline, who have done incredibly deep phenotyping of their clinical features, their cognitive features, their risk factors, their imaging findings, and CSF, etc. But one of the things I'd also like to highlight on this slide is the work that we're trying to do with organizations like Gates Ventures to create data platforms where the world can benefit from easy access to these data sets to allow investigators all over the world to look at these disease models and run research questions and test hypotheses. So a little bit of science. I think we probably would all agree that to a greater or lesser degrees, Alzheimer's disease, the process for Alzheimer's disease starts in the hippocampus. One would have to then give some consideration to how could you actually test the hippocampus in clinical practice, if you like. We know that the hippocampus, when you look at it through MRI imaging, can be subdivided into hippocampal subfields. And these subfields have been shown in preclinical or animal work to confer a particular cognitive function in mouse models, particularly the hippocampal place cells and the hippocampal grid cells. What do these areas of the brain do? Well, they're involved in visuospatial memory. So can we test the hippocampus using much more sensitive cognitive, and maybe even more specific cognitive tests? So one of the things that we've been doing in EPAD and also in the Prevent Dementia project is using this test called the Four Mountains test of allocentric visuospatial memory. The test is to look at these four mountains, which have a certain orientation to each other at a particular time of day. And what the person doing this test is asked to do is try to really remember these four mountains and their orientation, because after a period of time, they're shown four slides or four images, only one of which is the same four mountains from a different perspective. This is a very good test, if you like, of your hippocampal place cells. It's challenging, it's difficult, it's really hard. It's much harder, as you can imagine, to doing an MMSE very early in the course of Alzheimer's disease. The answer is A. Now, what we've shown in the Prevent Dementia project, and this is my colleague Craig Ritchie, who works from Montpellier, has shown that if you have a high risk of developing dementia through what's called dementia risk score, the CADE score, what we found was that people were high in the CADE score, high dementia risk, this is something you may be familiar with from the finger study, then they seem to be much, much worse at doing the Four Mountains test. The important thing, one of the most important things from this is the average age in this sample is 52 years old. High risk of dementia for later life, already showing cognitive changes that are probably related to an area of key pathological targeting, if you like, from Alzheimer's disease itself. And to complement that work that Karen did, looking at neuroimaging findings, Marielina Donavi and John O'Brien's group in Cambridge, again working with the Prevent Dementia cohort, showed that the hippocampal subfields that I was referring to earlier were atrophied associated with the individual's ApoE4 status. So one of the strongest genetic risks for sporadic Alzheimer's disease, if not the strongest genetic risk for sporadic Alzheimer's disease, ApoE4, was associated with much lower volumes in critical areas, molecular layer of the hippocampus in particular, as part of these subfields. And we know from pathological studies, post-mortem studies, again, this is an area of the brain that's affected very early in the course of Alzheimer's disease. So many of you have heard of the ATN criteria, amyloid, tau, neurodegeneration. And I think to the most part, we expect abnormalities in amyloid, abnormalities in tau, abnormalities in neurodegeneration to be, if you like, late stage phenomena. What we're seeing now, and there's some other data we have around amyloid and tau status, is it may be possible in very early stage of the disease, and people, like I said, in their 50s or 60s, to add in neurodegeneration and a cognitive outcome, which would give even more specificity to that individual having very early Alzheimer's disease. So the compelling evidence, I think, that we're developing from a scientific perspective is accumulating. Almost every other month, every month there's more papers, there's more evidence that's coming out, which is supporting this hypothesis that Alzheimer's disease is present and developing many, many years, if not decades, before dementia develops. But in 2018, 2019, I got to the point really in my own mind of thinking, well, we can keep doing this research, we can keep doing these trials, we can keep doing these observational cohort studies, and we can keep publishing papers. But to really make a difference, we want to get these research findings into practice. So not only was there the data coming out of these projects, in conducting these studies, I was also having the opportunity to speak to the research participants, people in their 40s or 50s and their 60s. And what they were saying to me is, why, as well as doing research, is there anything we can actually be doing to protect our brain health in the future? And what can our children be doing in terms of changing lifestyle or doing things differently that might reduce their risk? So we thought it was time that we really got this research and these conversations into practice. So I spoke to the First Minister, Nicola Sturgeon, here in Scotland about 2018, and she supported our proposal to establish something called Brain Health Scotland. Anna Borthwick is the executive lead of Brain Health Scotland, and Henry Simmons, chief executive of Alzheimer's Scotland, is the associate director. And what we've done and if you want to look at our website, it's www.brainhealth.scot, but we've deliberately looked at our branding and our marketing and our communication all towards people in midlife and even younger. We've got a schools program that we're about to start in primary schools and secondary schools here in Scotland about brain health. We've deliberately gone after brain health rather than dementia prevention, because we believe that we want to be able to talk to people about brain health, which is relevant across the life course, whereas dementia prevention at the moment would probably only seem relevant to people in late midlife or early old age. And what we've been tasked to do, looking at the Lancet Commission report, looking at the way things are changing, perhaps already, is to see a very palpable reduction year on year of the incident rates of dementia across Scotland. And it's fair to say that we're not just caring about, in a parochial way, about what happens in Scotland. We think there's things here, opportunities here, learnings that we can have, which we can share with the rest of the world. And there's something called the Davos Alzheimer's Collaborative, where we're working very closely with countries in Mexico, Brazil, Jamaica, Japan, and the US to share learnings and experiences from this type of work. Just for the last sort of few moments, in 2017, we pulled a group together here in the UK where we really were looking in some ways at whether or not the NHS, the National Health Service here in Scotland, was ready, was it prepared if there were a disease-modifying therapy to be launched. And of course, we all know what's happened with aducanumab recently, particularly in the US. And we came to the conclusion that we probably weren't ready, because to identify people early in the course of the disease, we weren't being able to do that effectively in memory clinics where we didn't tend to use biomarkers. We tended to see people who were quite late in the course of the disease with a dementia syndrome. So we advocated in this paper in 2017 for the establishment of brain health clinics. And the brain health clinic would be very different from a memory clinic. Memory clinics, in the UK at least, are making a diagnosis of dementia and putting in place post-diagnostic support. Whereas a brain health clinic is different. It's about risk profiling, it's about early disease detection, and it's with the instigation of a personalized prevention plan. And the way to do that, in this cartoon, I'll go through it quickly, is to say that let's remember that four-factor modeling. We want to be able to look at individuals' overall risk of developing a dementia syndrome in the years ahead. But we also want to know what's driving that risk. So, excuse me, in this individual's case, it's his lifestyle and it's his diabetes, in the red and the purple. So the personalized prevention plan would be to optimize his diabetes management and to maybe suggest he loses some weight. And when he comes back and you rerun the algorithm, the diabetes is better controlled and the weight has gone down, even though his age is advanced, his overall risk is reduced. But in that 10-year period, there probably wouldn't be 10 years between clinic visits, but in that period of time, maybe the amyloid has started to accumulate or the tau has started to spread. So in that individual, then is the time for a specific targeted intervention on the amyloid or the tau. And lo and behold, once that's managed effectively, the risk has gone down even further, even though the age has gone up. In effect, this gentleman has had a dementia syndrome, which was likely at 60, reduced to being very unlikely when he's in his 80s. Of course, this is just a cartoon. These aren't real numbers, but this is the kind of the approach that we'd be taking. Very busy slide. I apologize, it's deliberately horrible because I just wanted to show this needs a lot of, dare I say, work. It needs a lot of assessment. It needs, the detection of the disease through biomarkers, the brain imaging, the lifestyle, the sequence of follow-up. And critically important is collecting data all the time in these clinical services, so we can always be updating through machine learning those risk prediction algorithms. A nicer way of thinking about this is that how does this sit with what we call our sort of brain health ecosystem? So I mentioned earlier on when I showed you the Lancet Commission report that the two challenges, the two parts to the first challenge about how do you turn it into practice. Yes, there's working with individuals in brain health clinics, but the second part is how do you work on primary prevention, if you like, at a public health and a policy level. This is where you talk to primary schools, secondary schools. We're working through a lot of big employers in Scotland to start having that brain health messaging in people many years to set the tone, if you like, many years before even Alzheimer's disease would be expected to start accumulating. However, if there are high-risk populations, and we work very closely with ex-sports players and rugby players and football players, if there are a high-risk population, and we work very specifically with them, and we also develop, like I say, these brain health clinics at the individual level. What would happen in a brain health clinic? We're planning open door access, so people can come in from the community into what we call a brain health hub. They'll have an assessment, they'll get some advice. But if on the basis of that assessment it's deemed that they may be of higher risk by this triage point, if you like, then they'll see a nurse, there'll be more detailed assessment. If on the basis of that more detailed assessment, they end up in this cartoon as a red patient, then they'll see the doctor who may look at the brain scanning that's been organized before, look at the blood test, look at the genotyping, etc., and then put in a very specific personalized prevention plan to that individual. So last slide. In summary, I think we're seeing now compelling evidence and an overwhelming, I think, pivot in the research direction towards identifying disease models and expressions of disease well before the dementia syndrome, moving away from the concept of dementia being Alzheimer's disease being a cognitive disorder, rather to conceptualizing it as a brain disease that has cognitive symptoms. And the science behind this, from various sources around the world, but I've walked you through some data from the Prevent Dementia program, which I say a huge thank you to the Alzheimer's Society, who backed us way back in 2013, before anyone believed really that dementia was preventable. They supported us. And finally, Brain Health Scotland, about taking this research and this research direction and putting it into practice, and at the same time concurrently collecting real world data, so we're always improving those risk prediction models and being able to apply it in a real world population where at the end of the day we want to practice. So thank you so much for listening, and I'll leave you with a nice image of Glencoe, the west end of Glencoe here in Scotland. So thank you so much for your attention.
Thank you, Craig, for this great presentation. I have a 1 in 3 question for you. How do you envision the future of brain health services? Do you think that gene therapy, technology, cognitive enhancers pills will prevent dementia? And which are the risks that you envision about the future of these brain health services?
That's a really great question. I mean, I think we're very much at a learning phase with these brain health services, and as such, as a new initiative, we have to be careful. I mean, as you know, the first rule of medicine is do no harm. However, if one targets risk factor modification as the starting point for personalized prevention plans, you're probably not doing any harm for advocating smoking cessation or diet management, etc. There are potential harms that come with risk disclosure. How do we convey ApoE status, amyloid status, tau status to in effect a preclinical population without running the risk of increasing anxiety and concern? And I think this is something that we've done a lot of work on. There's work with Jason Karwalish in the US, who's working on the A4 program. I think, how do you communicate these risks to individuals so they can be actionable, they can be empowered, and not depressed and distressed? So these are things we have to learn about. I see the future, dare I say it. I mean, I think the future is kind of obvious in a way. I think every branch of medicine, for time immemorial, has always tried to seek out the earliest stages of the disease. I think the model that we probably most closely aligned to is our colleagues in cancer medicine and oncology, where, you know, if you turn the clock back 50 years, unfortunately, most people presenting to oncologists had quite late stage disease, it had spread, it was very symptomatic. And yet now we have breast screening, cervical screening, bowel screening to really pick up those earliest stages. And of course, what happens is the prognosis is much improved. So I think one of the challenges about risk disclosure is, are you exposing people to risk disclosure and saying, well, you've got this, you know, pathology in your brain. If there's nothing you can do about it, maybe it's still important to tell people if they have a concern about their brain health, but it becomes much more in some ways appropriate to share risk if there is an action you can take, if there's something you can do. Now, I think many of us will agree that aducanumab, the disease-modifying therapies, wonderful advances. However, most people would probably agree they're still being used too late in the disease process. Can you imagine a world where we could pick up somebody with the earliest amyloidosis in their brain and give them a 3-month course of aducanumab and just get rid of it? Then probably it'll take another 10 years to accumulate. That has to be the future. I think the future has to be using disease-modifying therapies at the earliest stages of the disease, not at the earliest stages of the syndrome. Gene therapies, I think, are really interesting because it's not a huge area of expertise of mine, but of course, PS1, PS2, APP mutations, fully penetrant, autosomal dominant. If we could do something to affect the impact of those genetic mutations on the disease, of course we could and we should. One of the things that we're finding from the PREVENT study is that ApoE4, before the age of 50, seems to be conferring some advantages to brain health. We've actually seen, and there's actually studies from Brazil which have shown, and we've seen similar data from a study that we're working with in China, where people in their early 20s who are ApoE4 positive have seemed to have greater cognitive resilience, better performance at school and university than people without ApoE4. There is something about ApoE4 which gives, I think, in a neurodevelopmental sense, some advantages. So we don't want to apply a gene therapy to a gene that might be doing a lot of good until you get into later life. So I think there's a lot we need to learn before we do that. I think cognitive enhancing medicines, I mean, I think I've answered that question in some ways. I mean, when I've said that, I think this is a brain disease with cognitive symptoms and not a cognitive disorder, because, you know, at the end of the day, cognitive enhancing drugs are symptomatic. They're whatever degree of disease you have, you will perform better if you have a cognitive enhancing drug. But as you know, with the cholinesterase inhibitors, memantine, they do nothing for the disease process. So a bit like a painkiller or an antiemetic in cancer, they're a huge benefit for well-being and for quality of life, but they're not, I think, what you would seek to sort of prioritize in the early disease process. We need things that affect amyloid tau, neuroinflammation, cerebral blood flow. That's where we should be targeting things. So it's a brilliant question, and I give it's kind of another lecture in response, Julian.
Thank you, Craig, again for sharing all your knowledge with thousands of people of the general public from our community.
Thank you so much, Julian. It's lovely seeing you again.
See you.
Bye.
Ahora vamos a darle paso a la siguiente sesión, que es la mesa sobre educación, que se llama en este caso La educación del futuro. Es hoy, ¿cómo hacemos? Estará moderada por la licenciada Florencia Salvareza, que es la directora del Instituto de Neurosciencias y Educación de la Fundación INECO, y contaremos con especialistas reconocidos mundialmente en este tema. Quédense ahí, no se vayan, que en breve comenzaremos con esta sesión sobre uno de los temas más relevantes para nuestro presente y futuro.